Hello, this is Jonathan Wick, Vice President of Healthcare Insights at FinThrive. I wanted to talk to you today about a popular subject, denials with a capital D, breaking the cycle of inefficiency in RCM. Let's dive into the content. As we think about what's happening in the healthcare market today, there's been shrinking margins, and I like to frame this surrounding the three-headed monster. Really, it is a result of these three factors: volumes, expenses, and relationship with payers that has caused margins to shrink over time and specifically caused some of the losses within the denials realm. Let's start with volumes first. We've been tracking volumes at FinThrive for some time. These represent hospital acute visits in the outpatient, ED, and inpatient settings, represented by the colors here in front of you. Outpatient obviously has the most volatility on the top, but I want you to look at the right side of this graph. There really is a tightening of the band as we've seen recoveries and some stabilization in the acute care market in the past probably year or so. I'm not going to tell you the whole story of COVID. I think we know that. Just know that the negative numbers on the right are important. We have not recovered to pre-pandemic volumes in 3 years. And I don't think those volumes are ever going to come back. There was a fundamental macroeconomic shift to patient visit volumes. And I think they've either gone other places like telemed, urgent cares, things like that aren't affiliated with the hospital, or they haven't gone at all, which is somewhat more scary. We had a really, really challenging 2022. I've been in healthcare for quite some time, and I think that the margin deficits that were created based off this three-headed monster we're going to talk about really caused some market headwinds that have made it difficult to manage your insurance claims and your denials, workflow processes. We are in a recovery, as you can see on the right. I think as of August of 23, we're about single digits. We still have some work to do. There was quite a bit of deficit created in 2022. We'll continue to monitor this. This is a Kaufman Hall report. In that report, Eric Swanson, one of their principal analysts and their senior vice president of data, had these 6 points, which I thought were really relevant to this denials discussion. Margins are stabilizing, and that's allowing folks to put resources in place, be them people, process, or even technology, to allow folks to work denials a little bit better. We've seen hospital length of stays or the complexity of cases decline. That will impact your denials in terms of your inpatient medical necessity or short stay denials as we move forward. Expenses have still increased, however, and labor, one of the heads of that monster, tends to be one of the largest ones and representing the biggest factor there. Hospitals need to reinvigorate financial and capital planning efforts that may have been put on hold. I think this is important. So you may have had a denial management or denial prevention task force. You may have had an operational expense or capital expense project that has been put on hold. These decisions are going to vary, but you can't be complacent. There is a cost of doing nothing. That's a decision to not make a decision, and that is resulting in revenue leakage. And denials we'll see here in a minute, have dramatically increased, and it's important to make sure that you've got a process and the right people, and more importantly, I think technology in place to manage these. You used to be able to hold during these financial pressures, but during the recovery and where we're at, it is time to revisit those. And I would really focus on your relationship with payers as we move forward. We talked about labor, and this is what I like to call kind of my crocodile graph. It comes from the Bureau of Labor Statistics. It's called a JOLTS survey, JOLTS, Job Opening Labor Turnover Survey. I'm going to walk through it really quickly with you. The orange line is how many people have been hired in the healthcare industry, and the green line is how many positions are open. And you can see, if you were to take that left side of this graph and run it all the way back, there'd be basically about a 500,000 deficit. There's always about per month 500,000 positions being hired in healthcare, and there's roughly about 1 million that are open, and that makes sense. We had COVID happen there in the middle, and with COVID, we had a dramatic loss in hiring, and then a huge influx, especially in the nursing area, as we were handling those surges during COVID. But I think what's most important is we've seen just this bifurcation or this increase in the delta here. It's at 1.3 million now difference. And my point with this is that there are so many openings. A lot of people have just left healthcare. They didn't sign up for being on hold with insurance companies, managing denials or fighting them. If you're a clinician, they did not sign up for COVID and having all these folks expire and having to speak to families, day after day after day. And so I think that's going to be tougher, with labor as we move forward, getting this curve down. Now you're seeing it slowly start to close its jaw, if you will. We've got some, freezing and unfreezing of positions there. I've been monitoring this very, very closely. August numbers weren't quite out yet at the time of this recording, but I still think we've got probably, if you look at that curve, it's not going to come down as quickly as it went up. I think we're going to be, in that 1.5 million range, probably for the rest of the year. We might dip down to where we were 4 years ago. But my point is that there are a ton of open positions in healthcare right now, which means there's increased competition to get the right skills in your organization, especially in revenue cycle. That's a national workforce right now. And so working your denials with labor is probably not a good sustainable strategy for the long term. You're going to need to look at technology to automate a lot of those processes. Another reason why the market has had such headwinds is there's really only 25% of business operations that can be effectively negotiated. I call this the 75-75 conundrum. It's borrowed from a gentleman named Kevin Holleran from Fitch Ratings. Him and I know each other pretty well. And anyway, his point was, on the expense side, your labor and your supply costs are pretty much defined for you as an organization. As we were talking about labor, that was one of the number one reasons why there was a negative impact. And I think you're going to continue to see labor pressures, and hospitals and health systems and providers, for that matter, trying to become more efficient and less reliant on labor and really automating a lot of processes through technology, because they just can't afford to have that much of a cost to their organization. And any little percentage point that can move in that light green wedge on the expense side will help. On the payer side, and this is specifically related to denials, government is having its own share of issues with Medicare Advantage. There's actually a bill that's out there that's being looked at to look at inpatient medical necessity, following the 2 midnight rule, to where private plans have to follow that. And then secondarily, there's a lot of work being done on the commercial side. And we'll talk about denials here in a minute. My point is that between government, which is Medicare, Medicaid, TRICARE, CHAMPA, those types of plans, Medicare Advantage, and self-pay, that's about 75% of most organizations' payer mix. And that's pretty much defined. Medicare and the government aren't picking up the phone and calling hospitals and saying, hey, what rate would you like? Do you like this rule? They ask, but most of the time the rules are kind of defined for you. On the commercial side, there's only about 25% opportunity for negotiation there as well. So it's very hard to change your margins and really affect the denials package as well with a small portion of your payer mix. And so we'll walk through some strategies on how to do that here in a minute. But I just thought it was important that the cards are kind of stacked against you from a labor standpoint, in terms of that it's highly reliant on manual processes and people doing those types of tasks, that the technology still requires someone to move those chess pieces around and pick up phones and update things. And then secondarily, the market in which you can impact on the commercial side is fairly slim. AHA, the American Hospital Association, has recognized this. We're into that third head that I mentioned of payer relations now. Payers are playing hardball. The majority, as you can see in those bullets, of hospitals and health systems report increase in staff time on prior auth. 84% report that labor cost of having folks, argue or have discussions with insurance companies is increasing. 62% of prior auth and 50% of initial claim denials are appealed or overturned. So that's a waste of everybody's time. The majority of these types of determinations are something that if you fight hard enough, you ultimately get paid. But that's administrative waste on both the payer and the provider side. And it's getting worse. More than 3/4 of hospitals and health systems have reported that they feel the relationship between their payers and them is getting worse. It's not getting better. And it shows. This is probably one of the most alarming slides I'll show you today. If you've been working in the industry long enough, you've always tried to keep your denial write-offs, the dollars that ultimately get lost, right around that 1% benchmark of net patient revenue. They creep up from time to time. COVID had something to do with that as well, and some others. But we have seen, and these numbers come from HBI Clarivate, almost a 4% denial write-off rate as a percentage of NPR. That's nuts. That's almost quadruple of what it normally is. And that's being felt everywhere. I travel the country quite a bit in my job and sit in sessions at conferences and talk about providers. They absolutely indicate the number one issue is denials. It was my number one issue when I was running my revenue cycle as a chief revenue officer. But they're also adding, and they just seem to be really bad right now. Like they're really nasty. They're denying things that typically got paid, and they're having to jump through more and more hoops. And there's reasons for that. That's a whole nother talk on why payers are doing that. It has a lot to do with margins and managed care. But my point is that the game's getting harder. You've got less people to work on it. You've got less negotiating power just as part of your payer mix. And there's more things coming through, more inventory from a claim standpoint that are at risk of ultimately being denied. You're outgunned, I think, as providers. I think payers, have automated rules. They have a lot of technology. They got a lot of resources. There really isn't an incentive to pay claims quickly. They have a lot more power than does the provider, who has fixed resources, a very mixed inventory of claims going in and out, not a super huge part of technology. They've got some things, but often they're relying on incumbent EMR technology like an Epic, a Cerner, or an Oracle Meditech. And really, needing a level of a sophistication of a third-party technological stack that allows, from a platform perspective, a longitudinal view of a claim and understanding the root cause of those denials and preventing them downstream, and also just holding the payers accountable to their own contracts. That's very, very difficult to do in an EMR format, in my opinion. I think you need to have contract management and contract analyzer analytics that allow you to understand as a provider where the contracts are not performing in your favor and what provisions are there and what is causing those denials to occur as you move forward. These are just some general statistics from HBI. Again, I like to show these. These are a little dated, but they haven't changed much, and I would argue they're probably worse now. Most providers I talk to have about a 1 in 10 initial denial rate. A minute ago, we were talking about an ultimate write-off rate, but this is a 1 in 10, and they vary. They spike in certain parts of the country. On the West, inpatient, for example, in the orange there, has a 14% initial denial rate on inpatient for commercial payers. Over on the East, that number is very similar. ED, runs about 15%. That makes sense. And typically those aren't denials on the claim, they're denials on the level. So like those E&M levels, they're being downcoded, or there's just not enough documentation to support the intensity of service. Top reasons for denials absolutely are not medically necessary, and you could put in that category, no prior auth, it's down below there in blue, but some of those things are the same, especially on the inpatient side. Dupe claims, more information needed. And then you can kind of see the breakout, and it goes across all different kinds of hospitals for that matter. There is a new operating model that is needed now as you talk through and understand that three-headed monster of labor and your payer mix, and frankly, just understanding, where you're at from a volume standpoint. So you've got less things that are getting harder to pay with less people to work on it. And you've got a contract that's not working in your favor. That really does start to make the denials management game much, much harder. as I mentioned, things have kind of stabilized. We've seen FTEs per adjusted occupied bed decrease. So that's huge. So indicating higher levels of workforce reductions, right? So there are those less people. I love this quote from Eric. He said, "This new normal is an incredibly challenging environment for hospitals. It's time to begin developing and implementing a strategy for long-term," he didn't say short-term, long-term sustainability, expanding their outpatient footprint, which really would diversify that portfolio, right? In terms of relying on people coming through your door, you're actually pulling your patient base in. But with that comes increased risk of payer regulations and rules that can impact payment from a denial standpoint. Well, now that I've talked through, what's going on with the three-headed monster denials, let's transition, per articles that I've written and others, just about how you can, really remove this cycle of inefficiency. These are areas in the front, middle, and back of the revenue cycle where we can have an impact. And it's all, everything's not a nail, and FinThrive certainly isn't a hammer, that has those things and others. My point is, this is a good checklist to look at in each of these areas to make sure that you've got, best in class, battle tested workflows in each of these areas in dark green here at the bottom to make sure. I'll give you an example too. You really want to look at these hard. You want to go deep on every one of these. Eligibility. Every single one of you that's listening to this webinar probably has an eligibility clearinghouse, partner of some sort that's running that for you. If you're not, please call me. but most folks that I talk to have, an electronic process in place to where a 270 or the ask to the insurance company is kicked off, and then the 271 comes back, and that's the answer from the insurance company, saying Jonathan Wick, effective data coverage 1/1/23, all that fun stuff. The CFO's $1 million question, or in some organizations, $10 million questions, is, hey, if you're running that, how come I still have eligibility denials? Well, my opinion, and I've validated this in the market, is that we run eligibility, but we don't do eligibility. And there's a very, distinct and measurable difference in those two statements. Running eligibility means you actually went out and did the transaction and recorded it. Doing eligibility means you're looking at that response and changing your workflows to prevent revenue leakage. And so, did the response come back and say coverage not found? That account, by all technicalities, should switch to self-pay, and then it should be handled through the self-pay process, which I'm sure is very rigorous and deep at your organizations. And it's not wrong. It's not meant to disrupt the patient. It's just to make sure things are in place, because what will happen ultimately is a bill will go to the patient if there are eligibility issues. Other things that I've seen happen is, well, the registrar didn't type it in right. Well, the eligibility response would have came back indicating that. So it really needs to be hardwired in your organization. Eligibility is a very large, if not the largest, proportion of denials for organizations. And so if you're checking that eligibility box and all these other green ones, make sure that you've got a hardwired process to where you're actually doing these steps, not just running a transaction for the sake of running it. Other challenges, specifically on one of the heads of monster labor, we're seeing in the market hold times, lines, DNFB growth, AR days growing, margins we've talked about deteriorating. Staff is also, again, you're competing nationally for it, but also they didn't sign up for being on the phone or doing the same things over and over again. And those technology stacks can be applied in each one of these, having things that look at your pre-access team. Access coordinator is one of the solutions that we offer at FinThrive. You want to have that frictionless patient financial clearance process, right? AR recovery. How are your $0 claims being worked, and how are your legacy EMR, if you've just transitioned, being managed? And where are dollars getting stuck, and how many touches is it taking you on a claim to recover said dollars? And how can you have your staff work on the right claims at the right time with the right technology that has the right outcome, right? to where that touch generated revenue. If it didn't generate revenue, it shouldn't be touched in most cases, right? And technology is moving this data around to where we're not having folks have to do it. It is all about retaining your staff right now. And denials are a very complicated workflow with a lot of repetitive processes that have high variability too. And most of the staff, if you talk to them, are like, why are we doing it this way? They know there's a better way to do it. They've talked to other hospitals, they've talked to other folks at conferences, and it's like, we need to have an automated way to manage our deficiencies. Kind of bringing it back home here are those three themes again, or the three heads of that monster: volumes, labor, and payer, and the impacts to revenue cycle with each. And I'm not going to go through this, in detail with you. Just understand that this is a great grid to look at to go, hey, here's what's happening on the left. Here's how it's impacting my revenue cycle specifically and creating inefficiencies. And here are opportunities to automate or put technology, people, process, and technology, I would add, into that specific area to manage that. And again, we're doing that. You could look at that list on the right and say, yeah, we're doing contract management. We're doing denials prevention. We've got a revenue integrity team. How are they doing? And are they saying it or doing it? And there is a difference. It's important to look at that and specifically measure at each step how many dollars are being leaked, and then try to fix it by 1 to 3 to 5%, a quarter. Just show incremental improvement as you move forward. That's it. If you need to get a hold of me or you had questions from today's webinar, it was a pleasure. You can scan that QR code or you can also follow me on social media there. If you need anything, again, Jonathan Wick, the Vice President of Healthcare Insights at FinThrive, talking to you about the D word, denials, and how you could break the cycle of inefficiency at your organization. Thank you and have a great day.